Greetings, my name is Munkombwe Samboko, and I'll be taking you through sustaining viral load suppression in the DSD-plus program on behalf of Howard University. The outline of my presentation is as follows. We will talk about what Howard University does briefly, our scope of work, our demographics, and then we'll dive into the abstract and look at the background on sustaining viral load suppression in the clinics, our methodology, our results, conclusion, recommendations, and finally a quick look at the authors. A quick introduction to DSD Plus is that the Howard University DSD model started at Material General Hospital in 2017 and is currently being implemented at high-volume facilities across 3 provinces, namely Lusaka, Southern, and Copperbelt. Key features that differentiate DSD Plus from regular DSD fast-track clinics is that we have a client-centered approach and flexible and extended hours of operation. We also offer a multidisciplinary team approach to healthcare service delivery and a proactive appointment scheduling, where clients are given appointments not only by date, but by time, with the clients having a say in their on when they prefer the next review appointment to be, which is what we are calling concordance. We also provide a 6 MMD for ART and also TPT, and we check on our clients monthly, virtually, to assess adherence, amongst other things. The plus in the DSD plus is because of the value-added services that we offer, like appointment reminders, same-day missed follow-up, pharmacovigilance, and other value-added services that make the DSD Plus clinic a one-stop shop. So 125 we are at 6 facilities. We have a mix of facilities where we're providing direct service delivery, as well as facilities where we're providing technical support. So our TX curve covers about 11% of the national TX curve, and we have more females than males on our TX curve at 66 and 34% respectively, with 90% of our clients being in the age of 25 and 59 years. Our provincial TX curve across the 3 provinces is 28%, 16%, and 5% respectively in Lusaka, Southern, and Copperbelt province. So a quick background on our abstract is that viral load suppression is a very important tenet in the DSD Plus clinics in Zambia. How we have managed to maintain suppression in our clients is that we employ a 3-pronged approach to maintain viral suppression, which consists of patient education, appropriate regimen prescription according to the national guidelines, and patient follow-up systems in between clinical interactions and drug pickups. So this study aims to describe the trends and investigate the predictors of viral load suppression and viral load rebound among HIV-positive clients that are accessing ART services through the DSD Plus model. So in our methodology, we looked at routine clinical data of a cohort of HIV-positive patients that were accessing ART services through our model at 4 sites in Lusaka, namely Chilenje, Chawama, Matero, and Kanyama. All of the clients had been virally suppressed at the point of enrollment onto the program. A cutoff point of more than 1,000 copies per mil was used to determine the viral load rebound, and the results that we received were analyzed for a 27 months follow-up period to determine the viral load suppression rate. Trends in the viral load rebound were examined by age, gender, facility, and ART regimen. So we'll have a quick look at the results, which are going to be disaggregated against the cohort by age, by facility, by regimen, and by gender. So out of the clients that we saw during this period, which has been split into quarters, as you can see on the bars, the green portion represents the clients that were suppressed, and the orange portion represents the clients that were unsuppressed. So out of the entire cohort that we looked at over this 27-month period, we found that 99.03% of our clients maintained their viral load status and were suppressed, and we only had 0.97 clients that were unsuppressed. I'll take an example of the quarter from July to September 2019, where we had 6 clients out of 1,765 clients being virally unsuppressed, giving us a percentage of 0.34%. So we can see that the DSD Plus model is very cardinal in maintaining suppression in our clients. When we disaggregated this data by facility, we found that Matero General Hospital had the lowest rate of viral load rebound at 0.57% as compared to Kanyama, which had slightly higher at 1.30%. When we disaggregated the data by gender, it was noted that we had a slight difference between the females and the males, in that the males had a viral load rebound percentage of 0.97% as opposed to the females at 0.84%. And this could be attributed to the adherence practices of the males generally on treatment. When we looked at the disaggregation by age, we found that clients that were between the ages of 18 and 20 years old had a higher rate of rebound as opposed to those that were with growing age, for example, those above 60 years old. So we can see that out of 682 clients that were assessed during this period in the 18 to 20 years age group, we found that 17 of those were unsuppressed, representing a percentage of 2.49%, as opposed to those that were more than 60 years old, that we had 5 clients out of 1,400, representing a percentage of 0.36%. Upon disaggregation by ART regimen, it was noted that clients that were on TDF, 3TC, and DTG were at less risk of developing a viral load rebound at 0.63%, as opposed to those on TDF, 3TC, and EFV at 1.09%. And this was attributed to clients being on TDF, 3TC, EFV, experiencing a lot more adverse drug reactions as opposed to those on TLD. I should mention that we took a lot of steps in managing the adverse drug reactions that were noted in the clients on TOE to ensure that they would not present with a viral load rebound in the future. In conclusion, more than 99% of the clients enrolled onto the DSD-plus program maintained their viral load suppression status for up to 27 months during this follow-up period. There was some variability in the proportion of clients who experienced viral load rebound between the subgroups, and clients who had switched from TLE to a TLD regimen experienced significantly lower viral load rebound rates compared to patients still on TLE. Clients aged less than 20 years old experienced a higher viral load rebound as compared to the older age groups due to adherence practices. So we recommend that the DSD-plus program can be implemented and should be implemented in high volume facilities, as it has yielded good results in terms of virus suppression. And the DSD program should be expanded to provide ART services to clients who have achieved a viral load suppression status. Transitioning from TLE to TLD or a DTG-based regimen should be expedited in all our facilities, and clients aged younger than 20 years require special attention to improve adherence and treatment outcomes. This is a list of our authors. We have contributors from our home office in Washington, DC, the regional office in Pretoria, and the country office here in Zambia. Thank you very much.